step in our program. We'll be presenting the winners of the talks that were submitted to us. So I'm gonna present the first oral presentation, and the presenter will be Dr. Jwalant Patel. So, excuse me if the name is not exactly pronounced properly. And he will talk to us about how we can continue the antiplatelet therapy during the perioperative period in spinal surgery. Okay, Dr. Patel, do you want to share your screen now?
My screen.
Okay, we can see that. Yes, you have 3 minutes to tell us how you do that. Yes, hello. Hello, carry on, please.
Perioperative continuation of the antiplatelet therapy in lumbar spine surgery is always a controversy. There are certain unanswered questions and burning questions which are still unanswered in the literature, like whether we should continue antiplatelet therapy or discontinue. If discontinue, how many with the aim to evaluate the and what are the perioperative bleeding related complications. In a single center retrospective comparative study, including 15 undergone single level number minimally invasive spine surgery like tubular decompression, tubular bleeding disorder, and revision surgery patient. We evaluated the operative time, bleeding disorder, and spinal hematoma. This is the table showing patient demographic data. We divided the patient into the 3 groups, and there is no much significant difference between the 3 groups. However, the tubular decompression was the commonest surgery, and division of the complication, there was not much significant difference with respect to the mean surgical blood loss, mean operative time. However, the mean hospital transfusion or developed spinal epidural hematoma. So, if we review the literature, those who have evaluated the effect of antiplatelet therapy in the lumbar minimally invasive spine surgery, we believe that tamponade effect, while we remove the tubular retractor, the muscle and the soft tissue mass collapse, and this provides the protection and prevention. However, there are no national or the international guideline whether we should continue or discontinue. It is still a controversy. However, from this study, we can conclude that the MIS provided tubular tamponade effect and antiplatelet therapy in perioperative blood value the risk and benefit ratio while continuing.
Okay, I don't know if you hear, but I think we have lost Dr. Patel. But anyway, we are going to the end of the presentation because of time issues. Thank you so much, Dr. Patel. Next speaker is Dr. Wu from Singapore, and he's going to talk to us about comparison of uniportal endoscopic versus laminectomy approach. Yeah, please carry on. We don't hear you, Dr. Wu. Are you unmuted?
Yeah, so just a moment. I'm going to share my screen now.
Okay, we see your screen now. You please carry on.
Can you put it on presenter's mode or? Can you
just
put
a moment.
Presentation mode, Doctor? Okay.
Okay.
Perfect.
Yeah.
Yes.
Okay. So can you all see my screen?
Yes, we can see your screen. Please carry on.
Okay. So I'm Dr. Pang Hong Wu. I'm from Singapore. My topic is comparative clinical and radiological cohort study, uniportal versus thoracic endoscopic laminotomy bilateral decompression using one block resection technique versus open. We have no conflict of interest. Thoracic OLF is an uncommon cause of thoracic myelopathy. For myelopathic patient, traditional surgical recommendation is open surgery. Despite improvement in JOA score in open surgery, many of the patients present with significant perioperative pain and poor functional status. Endoscopic spine surgery has evolved over the past 3 decades with better instruments, optics, and providing good degenerative surgical solutions from various anatomical regions. There's a lack of degenerative surgical solutions for the lumbar, cervical, and thoracic, as well as clinical results in the thoracic region for the MRI and clinical results. In our materials, we perform a retrospective, comparative, interventional cohort study on patients with a JOA score of less than or equal to 10 for thoracic myelopathy. We did preoperative and postoperative CT and MRI scans and evaluated the clinical outcome in VAS, ODI, and JOA at various intervals. 35 levels of uniportal thoracic endoscopic surgery versus 24 levels of open surgery is compared. This is a surgical video showing how we perform our technique. And as you can see, from the left side is T9 and the right side is T10. From the bottom is left side. We start with our laminal facet junction. We perform a T9 and T10 laminotomy, getting to the margin of the OLF. And within the OLF as a single block. And that helped us to lift it off with a probe or a forceps. With a thin epidural margin, we can see clearly the margin of OLF and can safely deliver the OLF off the dura. As you can see, most of the time, we can deliver it as a single block in this manner. In our results, we find that there's no significant difference in terms of the age and sex. There's a follow-up of a shorter period because of a new technique on endoscopic with a lower complication rate. In both cohorts, there's statistically significant improvement in terms of VAS, ODI, and JOA score. The MAGNEP score-wise, we find that the endoscopic group did better with more good and excellent outcome. Interestingly, when we look at the final VAS score as well as the JOA score, the endoscopic group have statistically significant improvement. And they have no statistically difference.
We have to wrap up.
In terms of the MRI cross-sectional area. So in summary, it is a safe procedure with a lower complication rate, similar clinical canal decompression with a good JOA and VAS score. In experienced hand, is a viable option for endoscopic one-block resection. Thank you very much for your time.
Thank you so much, Dr. Wu. It was an interesting presentation. The third presentation is coming from Brazil, and Dr. Fernando Danstas is going to talk to us about adjacent segment degeneration after lumbar fusion. Okay. Dr. Danstas, can you hear us? Can you share your screen now?
Yeah, I'm here.
Dr. Wu, please unshare your screen.
Can you see it? Deixa eu só compartilhar aqui.
Not yet, not yet. Please try again.
Can you see it? Can you hear me?
No, we can see you. We can see your screen now.
Is it okay?
No. Yes.
Okay, so I'm François Dantas from Brazil, and our study is about adjacent segment degeneration after lumbar fusion for degenerative pathologies. We performed a retrospective analysis of all patients who underwent fusion with pedicle screws posteriorly from 2000 to 2015 at a single private institution. There were several exclusion criteria, and these were the data that we analyzed. So 745 patients underwent lumbar fusion. 6% of them developed ASD that required a second surgery. The average age of the patients was 65 years. We had a long follow-up period with an average of 9 years. Lumbar stenosis was the main indication for the first surgery, and most commonly fused levels were L4S1. with an average extent of the assembly of 2.13 levels, so mainly short assemblies. We observed that most patients that developed ASD had an assembly beginning at L4 and ending at S1, and ASD manifested mainly with stenosis. As we can see in the figure, the average period of onset of ASD symptoms after fusion surgery was 6 years, with a peak at 8 years. The degeneration occurred above the fusion in 40 cases, and we had a total rate of complications of 15%, mainly with infections. Our treatment strategies were variable, and in our last cases, we preferred to perform simple laminectomy at the affected level and enlarging the assembly using 2 screws and 2 connectors to join the old system with the new ones, as we can see in this case. So to conclude, we believe that ASD is probably multifactorial in its origin. Our study demonstrates the assembly of F4S1 as a risk factor for ASD. Best surgical strategy is still debatable in the literature. And of course, our study has some limitations. It is a retrospective study of a single institution with no control group. And I would like to thank the opportunity.
Thank you so much for your presentation and for your timekeeping, Dr. Dantas.